So we're going to talk today about focal therapy of prostate cancer. It's kind of a hot topic right now internationally. So this is a picture that we all know. It shows essentially a depiction of an MRI of the prostate where we're throwing targeted biopsies through a region of interest. And it occurred early on in its natural transition that if we can accurately locate and biopsy an area of prostate cancer, why couldn't we just come back later and stick a needle into that area and destroy it? This is Dr. Gary Oenig. So the focal therapy concept was introduced in 2002. He's a radiologist out of Florida. And he started using cryotherapy for partial gland ablation. He was the first to coin the term the male lumpectomy and stated a male lumpectomy could have a profound effect on prostate cancer management. There have been some comparisons of focal therapy of the prostate to breast cancer. If we revolutionize the way we perform breast cancer, why couldn't we do the same for prostate cancer? This is a picture of Dr. Bernard Fisher. He was a surgeon out of Pittsburgh. He was a pioneer in breast cancer treatment, and a few of his obituary headlines actually read from heretic to hero. He was the first to essentially look into a lumpectomy and challenge the system because at the time they were still doing the Halstinian radical mastectomy for everyone. His results to justify lumpectomy as standard of care were published in a Sentinel 2002 New England Journal of Medicine article, and thus changed the landscape of breast cancer forever. But his trial got started in basically the early 70s, and so this is a time when people were very unsure about the long-term outcomes. It's kind of like our active surveillance cohort. So when comparing lumpectomy and mastectomy, they found no differences in outcomes and less morbidity with lumpectomy, but risk of local recurrence. However, recurrences usually occur 20 to 30 years later, and they're not always clinically significant. The breast cancer experience parallels the active surveillance experience, as with active surveillance, is challenging to train people to do something when you won't see the outcome for 20 to 30 years. As we know, the active surveillance approach has been in use for almost 2 decades, thanks in part to the great work from Dr. Klotz and his colleagues. However, the term male lumpectomy, it is a bit of a misnomer. In terms of breast cancer, a lumpectomy is a multimodal approach with surgery plus radiation. So a lot of the benefit comes from the added radiation. But right now, there really isn't too much research going to focal therapy plus radiation, if any, because that kind of defeats the purpose of trying to minimize whole gland treatment. And we've all seen this slide before about, is prostate cancer screening for you? A lot of buzz in the media about overdetection, overtreatment. In response to advances in prostate images and evidence suggesting that prognosis in prostate cancer is related to the index lesion, many patients have begun to offer therapy, which targets a lesion rather than the entire prostate. The index lesion theory was demonstrated by Dr. Stamey and colleagues, showing that although prostate cancers are multifocal, the pathologic characteristic of the largest lesion, aka the index lesion, are often the best predictor of the course of the disease and prognosis. This middle-to-ground therapy between active surveillance and whole gland treatment is appealing because the risk for side effects is believed to be lower with focal therapy than whole gland treatment. But prostate cancer is a pendulum. It can be a spectrum to the desire to have peace of mind for cancer control versus minimizing the side effects and maximizing quality of life. But in the end, the ultimate goal is what we term the holy trinity of prostate cancer therapy. So let's get into some of the compelling reasons for focal therapy. Number one, we now have a great ability to localize disease. This is extensively demonstrated through MRI of the prostate. And also, why not focal therapy of the prostate? We've had success in other areas. Sorry, I heard my audio is fading in and out. Let me just stop my video, see if that helps. So we've had success in other organs such as breast, kidney, and thyroid. In fact, not too long ago, the standard of care for a 4-centimeter renal mass was radical nephrectomy. And we now know that's not the case most of the time. There is also a there's also lots of questions about efficacy of whole gland treatment. This is particularly scrutinized in the days of over-detection, over-treatment. Whole gland therapy is still very much in our repertoire, but it's certainly lost some of its luster. As mentioned, the monoclonal index origin of prostate cancer stems from the theory that the index lesion drives the overall malignant profile of the prostate, and if we're able to ablate that index lesion, then it can help drive down the malignancy of the gland. And also just safety and patient preference. You know, focal therapy appears to have less major side effects. And when it comes down to it, most patients would certainly prefer a therapy that maximizes their quality of life. The key is finding a balance. So some of the advantages of focal therapy: it is targeted therapy. It allows for repeat therapy. It's an outpatient procedure. There's usually lower cost involved, less injury to the periprostatic structures, and as well as induction of anti-tumor response. So who's eligible? So this is the NCCN Intermediate Risk Definition and Recent Consensus Guidelines. This is basically a group of international folks who get together every couple of years and they publish their findings. So essentially it's clinical stage, less than T2C, serum PSA less than 20, region of interest, a multi-parameter MRI grade 3 or greater. And then they're defining it as grade group 3 in any core, or excuse me, grade group less than or equal to 3 in any core, or grade group 1 with maximum core length greater than 4 millimeters. They need at least 10 template and 2 targeted cores obtained, demonstrating unilateral carcinoma of the prostate. So this is a study by Dr. Marks and his group out at UCLA, and they essentially looked back to see who would be eligible for focal therapy determined by MRI ultrasound fusion biopsy. It was a retrospective cohort, and they basically took these patients and they compared them to pathology whole mount specimens, because that's the only way to really determine who's eligible and who's not. And they found that 38.5% of the patients of men with a biopsy-proven region of interest were actually eligible for focal therapy. These are obviously men that went on to undergo radical prostatectomy. There were 64 cases compared to whole mount, and they found good, not awesome, but pretty good sensitivity and specificity and accuracy of 75% with prediction of who would be eligible for focal therapy just based on the MRI ultrasound fusion guided biopsy. But we have to make a few concessions if we are to accept focal therapy. We have to concede that grade group 1 cancer is not lethal and does not require immediate intervention. We have to concede that small component of Gleason 4 disease does not require immediate intervention. We have to buy into the buy into the theory that the index lesion drives cancer aggressiveness. Multiparametric MRI reliably identifies clinically significant disease, and targeted biopsy improves risk stratification. So let's look into the types of focal therapies. There's essentially 3 different ways that you can go about, and these differ varying on the type of procedure performed. So you have a targeted ablation, which is a much more targeted area with an area that you ablate around it. You have a hemiablation, which is essentially half a gland therapy. And then you have a zonal ablation. They call this the hockey stick approach. This is a slide that Dr. Marks at UCLA had in one of his talks. They're essentially, there's lots of methods of focal therapy that are currently being investigated, but the 3 main ones that are currently in practice and the hottest topics are, you have cryoablation, HIFU, and laser. With cryoablation and HIFU, they're both in the OR under general anesthesia. With laser, it's a clinical procedure. It's all 3 a urologist can perform, but with laser, it can also be performed by a urologist, as it has the ability for MRI and bore targeting. Cryo is a hemiablation. HIFU is much more precise. Same with laser. The only one that's covered by insurance is usually cryoablation, and HIFU and laser are out-of-pocket cash. So what is HIFU? So it stands for high-intensity focused ultrasound. It's a non-invasive acoustic ablation technique that uses intersecting precision focused ultrasound waves. It raises the temperature of the target tissue to about 100 degrees Celsius. It destroys the targeted tissues at the focal intersection. The repeated bursts of ultrasound energy cause coagulative necrosis, essentially a popcorn effect, with rapid heat dissipation past the focal point. So it's essentially like a magnifying glass where you pass high intensity ultrasound waves through the acoustic lens, and you get that intense heat at the apex, but not before or after the apex. This is why it allows for, there's no incisions involved. It goes through the rectal wall, and you can definitely do damage to the rectal wall if you have that apex at the rectal wall. However, that's why the training is to focus it right at the area. So it's a very precise technique. And here's a setup. There's a couple of commercial machines available for HIFU. As you can tell, it looks like a big expensive machine. Everyone's having fun. The doctor's wearing Crocs, and apparently you can keep your underwear on during the procedure, which is a benefit. So let's talk about a sentinel study for the argument of HIFU focal therapy. So this is a multi-center study of 5-year outcomes following focal therapy and treating clinically significant non-metastatic prostate cancer. This is a study out of the UK with Mark Emberton and his group, Dr. Ahmed, with the University College London. So if you notice, over 70% of the patients were grade group 1 or grade group 2, so they were treating a lot of grade group 1. And also, if you notice, they're using a lot of transperineal mapping biopsies for 70% of their patients. It's very British and not always feasible in a US office setting. But they had excellent primary endpoints. At 5-year follow-up, they had a failure-free survival of 88%. They have a metastasis-free survival of 98% and a cancer-specific survival of 100%. And if you look at the complications, they're mostly Clavian grade group 1. Most of them are just urinary tract infections. That's the small amount of epidermolysis. A couple required endoscopic procedures for lower urinary tract symptoms. But then there's the dreaded rectourethral fistula, which only occurred in one patient as well. They also boast excellent continent rates. These are very, very high numbers. They show that 97 and 98% of patients at 2 to 3 year follow-up had 0 pads, and 100% of patients at 2 to 3 year follow-up had 0 to 1 pads. But there are a couple of weaknesses to the study. Only 222 out of 625 men initially enrolled underwent biopsy after treatment, so they weren't able to risk stratify all of the men after they received treatment. And thus, this understates true failure-free survival rate or rate of recurrence for all patients. They also did not report sexual side effects. So what if we combine the MRI ultrasound fusion platform? This is a study out of Germany, and they essentially looked at prostate cancer treatment by the latest focal HIFU device, and they used an MRI ultrasound fusion biopsy. It was a prospective evaluation. It was a single center study. They used MRI ultrasound fusion HIFU. It only had 24 patients. It was a small patient population. 19 had at least one PIRADS lesion, 5 with a negative MRI. 17 out of 24 patients had grade group 1, and only 7 out of 24 had grade group 2. 20 patients were biopsied at 1 year, but 8 patients had persistent disease in the ablation zone, but that comes up as 40%. And 4 patients were upgraded to grade group 2 or upgraded to grade group 3. So not looking great. But the side effect results were great. They showed that 20 patients, no significant decrease in urinary continence. The median decrease in potency, it only went from 19 points at 12 months on the, it only went down 2 points, excuse me. on the International Index of Erectile Function, and only one claving complication that was greater in grade 2. So let's talk about some of the advantages of HIFU. It's real-time visualization with ultrasound. They're also looking into technology to combine it with MRI ultrasound fusion. It is FDA approved, but I think that one of the biggest advantages that a lot of urologists are seeing are bills, y'all. And some of the disadvantages, it does require general anesthesia or spinal. It is not effective in prostate volumes less than 40 cc's. The treatment zone is only, the maximum length is only 4 centimeters. So it essentially cannot treat anterior lesions. And because of the platform with ultrasound, prostatic calcifications greatly limit the treatment visualization. It just gives a lot of artifact. In general, the post-op course, patients have a Foley catheter for about a week, and then depending on the institution, the PSA and repeat biopsies are at 6 and 12 months. Let's talk about focal cryo of the prostate. This is more known to our institution. This is just a depiction of focal cryo. So most studies with cryoablation are match studies using the cold registry. This is a nationwide database that pulls data from both whole gland and focal cryoablation. Here's a study published in the Journal of Endourology in 2015. It was a comparison of outcomes between preoperatively potent men treated with focal versus whole gland cryotherapy in a matched population. They used a 1-to-1 match using the cold registry of 317 men who went focal cryo versus 317 men who went whole gland therapy. The median follow-up was 58.3 months. 14.5% of the 55 men who underwent biopsy after focal therapy had a positive result, and 11.6% of the 95 men who underwent biopsy after whole gland ablation had a positive result as well. So we're still seeing high rates of positive biopsy in the ablation zone. The side effects, so it has similar oncological outcomes to other focal modalities. It definitely does have higher rate of erectile dysfunction because this is essentially a hemicrioablation, but it's shown to have low rates of incontinence. Now on to the third study. This is focal laser ablation. It's essentially placement of a laser fiber directly into the lesion via transperineal or transrectal approach. The energy transmitted creates a volume of thermal necrosis, and it creates a larger, more homogeneous and demarcated treatment zones versus HIFU. HIFU is more of a popcorning effect. It's like a coagulation necrosis. And this, it kind of looks similar to cryoablation where you see a nice demarcated treatment zone, kind of like an ice ball, except this is thermal necrosis. Most of these, this is definitely under investigation. It's a phase 2 evaluation of guided focal laser ablation of prostate cancer. It's published in the Journal of Urology in 2016. What they found is they had 27 men, low PSAs, grade group 1, 2, or 3 disease. At 3 months, 96% of the men were free from disease in the ablation zone. That was just on repeat MRI. They hadn't biopsied the men at that point. And at 12%, 89 of the men were free from disease in the ablation zone. That's after they actually got a biopsy of the ablation zone. So 11% reoccurrence in the area that they ablated. However, 37% had out-of-field recurrence on 12 core biopsies. So that was somewhere outside of the area that they ablated. The side effect profile is much lower with this. There was no significant changes in urinary continence or sexual function, but again, this is a low cohort. The most common adverse events were hematuria and urinary retention. This is currently the largest study that's ongoing. They published interim results in 2018 on 98 men. There is a 23% rate of in-field cancer recurrence. However, still no significant side effects. and no changes in the IPSS or the shim. The advantages: it does not require general anesthesia. It's MRI compatible, and it can ablate any area of the prostate. They are also working at UCLA on an MRI ultrasound fusion system for it. The disadvantage is the lack of commercial platforms. So I think that there are lots of issues ahead for focal therapy, though. I think that right now the treatment margins need to be better justified, given that we're having high rates of recurrence in the ablation zone, although you can argue that it's not always clinically significant. The long-term efficacy hasn't been well studied, and as well as the potential for abuse. But Hot Topic is not just a store where Jay shops to get his clothes. This is definitely a hot topic in the field of urology. If you were to Google focal therapy for prostate cancer, then you would see that there's 179 studies that patients are eligible to enroll in. So the take-home points: focal therapy is a hot topic. It's more suitable for localized grade group 1 or grade group 2 disease. The patients still need close follow-up, as in active surveillance, and there's still a need for robust long-term data. And I'll end with just the statement from the focal therapy and focal therapy group from the EUA. Their position was focal therapy of prostate cancer is the targeted destruction of cancer within a specific part of the prostate gland. It says that the procedure could potentially reduce side effects when compared to standard treatments. Studies show that for most men with low risk cancer, active surveillance is the preferred treatment option. However, the available data regarding all forms of focal therapy are still poor and inconclusive. Consequently, due to both the lack of clear results associated with focal therapy and the difficulties in detecting all cancerous areas of the prostate, focal therapy should be considered an investigational modality only. That's it. Questions?
Okay, Jody, can you unmute for a moment for questions?
I didn't see her that way. I can make it back. Otherwise, I'll have to do some of the phone visits at work, and then I'll come back later. But
Okay, maybe we should mute everyone. I'm not sure people are.
that ultrasound was at 11.
Cayce, that was very good. Cayce, I have one question for you. Can you hear me? This is Dan.
Hey, yeah, I can hear you.
Okay, so Cayce, I was just curious if someone has focal therapy and then they have a failure, does that make it more difficult to have definitive treatment afterwards? Say it was a younger person who was caring about sexual activity, so they had the focal therapy. Would it be difficult to do a prostatectomy on those patients? I don't know if Preston wants to weigh in.
So yeah, I was going to let Cayce go first, and then I'll.
Yeah.
Okay.
I think that definitely with a cryoablation, I think that it does, because that's essentially a hemiablation, and so you do have that area of necrosis that's right up to around the capsule. So I think that can make things a little more sticky. I think that if you're using HIFU or the laser, I wouldn't think it would ever make things easier, but I don't think it's as challenging.
So with any ablation, so the only difference between the two is with cryo is that it's using cold, and laser and HIFU are using heat. Both of them all of these that you discussed are thermal ablations. And so they have a significant reaction to a certain margin around the ablation zone. So it really depends on where they're ablated, Dan. So if it's an anterior ablation, things will be a little sticky there, but your nerve bundle should still be fine. And quite honestly, if someone's really worried about preserving their sexual function and having a focal treatment because they're trying to preserve sexual function, it's really only better if the tumor is in the anterior zone away from the nerve bundles. Because if you're trying to do a subtotal ablation near the nerve bundles, you're still going to potentially cause some damage there. I actually tell people with posterior lesions near the nerve bundles, they're better off having surgery, and they'll probably have better preservation of their sexual function with surgery than with an ablation, because you're going to destroy that nerve bundle to get your adequate cancer control margin. In terms of doing surgery afterwards, depends on how long since the treatment. If you're going in there within 6 months, it's going to be a little bit of a mess. If it's more than 6 months or a year, it's probably not that different. It's actually easier than a salvage prostatectomy after radiation, but you will notice some difference in tissue plane stickiness in the area of the treatment.
Okay, great, thank you. Okay, are there any other questions?
So I thought thanks, Cayce. I thought that was a really good review. Just to kind of summarize my perspective on it really quickly, I think ablation is very reasonable option. I think it's important for everyone to know about it because there are limitations. This is not the same cure as surgery or radiation. Those are the gold standard treatments. A subtotal treatment is completely with a first eye on maintaining or trying to minimize the side effects of treatment, and that primarily is urinary continence. They have great urinary continence rates. The impact on sexual function has to do with where the cancer is located, and it is not as good as surgery or radiation. So if the patients are willing to are interested in that trade-off, then I think a subtotal ablation is a great idea for them. But that's one of the reasons why I don't do a tremendous number of these. Is I very aggressively counsel people that, this is not as good cancer control, and this is for very specific reasons that you should be doing this treatment. Although I think it's a great option for people who are interested in that.
Dr. Kellner, I have a message from Dr. Singh. He'd asked if we can speak about the discussions regarding how recurrence is defined.
Okay, Cayce, can you answer that?
So it's essentially defined as a positive biopsy. Either there's in-field recurrence, which is in the area of ablation, and out-of-field recurrence, which is an area that wasn't detected on a prior biopsy. So when you're biopsying the whole gland via your targeted biopsy and your systematic biopsy, and then you have a new positive core away from the ablation zone. So, but again, unless you have a whole mount, then there's no great way to know if that was an area that was either that was just missed from your systematic biopsy, and then in the area of ablation, there's no way to know if that was an area that was missed by your ablation zone versus if it's a true reoccurrence.
And the limitation of that European study, the large one showing the benefit, is that they did only for-cause biopsies when people had a PSA rise. And I can't remember if they used Phoenix criteria or not, but very often we're kind of mixing things and using Phoenix criteria with a PSA rise, either a 3 successive rises or a rise to 2 points above the PSA nadir. It's not really clearly defined or universally accepted what is defined as a failure, and not everyone does biopsies. I do routine biopsies at 6 months and 2 years after any subtotal ablation.
Okay, are there any other questions?
I don't have any others from chat.
Okay, so I think we're going to move on now to Dr. Syed. Dr. Syed is going to talk about blue light cystoscopy for the detection of bladder cancer. So can Dr. Syed share his screen? Excellent.
Thanks. So today I'll be discussing blue light cystoscopy and non-muscle invasive bladder cancer. So I'll begin with a case. We have a 68-year-old male who's otherwise healthy, who's been having gross hematuria. He's also been endorsing urinary frequency every 30 minutes, as well as dysuria. He's had a prior white light cystoscopy that was negative. He had a CT urogram that was negative. However, he had a new positive urine cytology. He was then taken to the OR for blue light cystoscopy along with random bladder biopsies. So in order to do the blue light cystoscopy in the pre-op area, he had to get installation of Cysview. It's also known as hexaminolevulanate. And he got that 1 hour prior to his procedure. Here in the OR, under white light, you can see that in the background of this picture, there's a small papillary appearing tumor, and in the foreground, there's a sort of ill-defined patchy erythematous area. When you shine the blue light, you can see that the papillary tumor actually lights up hot pink, and that area of patchy erythema is actually a lot better demarcated now. This patient went on to have a resection and was found to have high-grade TA disease. He was treated with BCG and then subsequently has not developed any sort of recurrence that we found on surveillance cystoscopy. So blue light cystoscopy can be a valuable tool in the detection of bladder cancer, especially for patients who you have a clinical suspicion based on their cytology or their symptoms, or if they have a history of non-muscle invasive bladder cancer. So the objectives for this talk that I'm going to be discussing are epidemiology and costs of bladder cancer. I'll be discussing principles of transurethral resection and risk of recurrence for non-muscle invasive bladder cancer. We'll discuss the data that's currently out on blue light cystoscopy and non-muscle invasive bladder cancer. And finally, we'll talk about the AUA consensus statement on the office use of blue light cystoscopy. Currently, the gold standard for cystoscopy is white light. And I just want to be clear that that is still the standard. Blue light is not the standard for cystoscopy. Blue light's really used as an adjunct. And I think that the purpose of using blue light really stemmed from urologists trying to be able to better recognize bladder tumors to help perform a better resection. The question really is there room for improvement in how we do our resections and our recurrence rates for bladder cancer? So to better understand that question, I think we have to look at the prevalence and recurrence for bladder cancer. So in the US this year, there's an estimated 81,000 new cases of bladder cancer. Of those cases, a significant proportion, about 75%, are thought to be diagnosed as non-muscle invasive bladder cancer. So the majority of the bladder cancers that are going to be diagnosed are actually non-muscle invasive. And this table here is from the European Association guidelines on non-muscle of bladder cancer. And if you look at the recurrence rates, they're pretty high, 50%, although they quote even up to 90% for some types of bladder cancers. And we know that the recurrence for bladder cancer is correlated to stage and grade of disease. And because of that prevalence and because of the amount of recurrences that occur, bladder cancer is a very costly disease to treat. In 2020, it's estimated that $5.7 billion will be spent on bladder cancer. So it's one of the most costliest cancers to actually treat. When you look at the cost of bladder cancer in relation to other cancers, you see that it's higher in relation to colorectal, breast, prostate, and lung. And a lot of that really stems from the chronicity of care associated with bladder cancer. So up to 60% of the costs are actually attributed to surveillance and the treatment of recurrences. So are there ways to help us identify malignancies in the bladder to help us do a better resection? You know, our hope is that we would have less recurrences from an oncologic standpoint for our patients. And obviously, to help an economic impact as well. So transurethral resection is our first line step in the treatment for bladder cancer. Our goal is to diagnose the disease with the hopes of taking all of the tumor out and trying to avoid and delay disease recurrence and progression. Some of the important principles of a transurethral resection is that you map out all the tumor sites. You perform a complete resection when possible. You try and sample the muscularis propria. You perform an exam under anesthesia, and you do restaging procedures when appropriate. This includes patients who have high-grade disease, T1 disease, variant histologies, or patients who have had an incomplete resection. As part of the TURBT, reliable visualization is critical. Carcinoma in situ and other low, flat lesions can actually be difficult to detect under standard white light cystoscopy. So to study how often residual tumors are actually present after an initial TURBT, Dr. Herr at Memorial Sloan Kettering actually looked at 150 patients who had an initial TURBT and then went on to a second procedure 2 to 6 weeks after the initial procedure. Most of these patients had high-grade tumors. When you look at the rate of residual tumor at 2 to 6 weeks, up to 76% of patients had residual tumor. In the patients who had non-muscle invasive bladder cancer, 75% of patients actually had residual non-invasive tumor, and 29% were actually upstaged. This is another table. That data was updated in 2013 by the same group. And again, the point is that bladder cancer tends to recur very commonly. So patients who had TA, high-grade disease, 50% had residual tumor. For patients who had T1 disease, 25% had residual T1 disease, and 30% were actually upstaged. So to the question of, is there room for improvement on our gold standard white light cystoscopy, I think some people would argue yes, that there is improvement based on that data. So enhanced detection of bladder cancer was developed to help urologists better detect bladder tumors. They actually have been instilling agents in the bladder for visualization since the 1950s. It's when it all started. The NCI was the first group that I was able to find that was using installation agents, and then over time, we've developed into using Cysview. So Cysview was initially approved actually in Europe in 2005. It's known as Hexvix there. In 2010, it gained FDA approval in the United States. Cysview is also known as hexaminolevulanate. And the way it works is you actually instill the agent in the bladder 1 to 3 hours prior to the procedure. And then you take them to the operating room. You shine blue light using specific cystoscopes, and areas of interest actually turn hot pink. And so the thought is that the Cysview is actually taken up by the urothelium, and malignant cells take it up, and a photoreactive metabolite accumulates in malignant cells. And then when you shine the light, that's how you get this hot pink appearance. So this is just the kit that comes and that's given in the pre-op bay for patients. You need this kit. The patients get catheterized and this gets instilled in their bladder. There's also a separate tower that you actually have to use when you're doing the blue light cystoscopy. So it's been since 2010, we've had blue light cystoscopy available in the United States. And since that time, there have been multiple phase 3 trials which have investigated the differences in detection between blue light and white light cystoscopy. This is just a table showing the various studies that have looked at the differences in detection rate, and you can see that multiple studies have looked at this. There's a increased detection rate using blue light cystoscopy of non-muscle invasive bladder cancer from 16 to 41%. And I wanted to highlight one of those studies, which played a major part in blue light getting approval in the US. It was a study from 28 centers that had 286 patients who had bladder cancer suspected at their outpatient cystoscopy. They went to the OR. All the patients received a white light cystoscopy, and then after getting their white light cystoscopy, they were randomized into either getting blue light or not. And then they assessed the cancer detection rate. And so in this study, 16% of patients had an additional lesion on the blue light cystoscopy only. And of those lesions, 43% were high grade or T1. Of 41 patients who were found to have CIS on their TUR, 32% of patients had CIS only on the blue light. There was no false positive rate in this particular study between the blue light and the white light. There was also no difference in adverse events between the two groups. So they showed that detection was improved with blue light, or at least increased with blue light. And they also commented on recurrence. Is there any difference in recurrence? So they had 9-month surveillance, and in this particular paper, the recurrence rate for the patients in the blue light group was better compared to those who had white light, so 47% compared to 56%. Since that time, there's also been a different study. This is a meta-analysis that looked at 6 prospective studies and the rate of detection for blue light cystoscopy. So there are 1,300 patients in this meta-analysis with 12-month surveillance. And again, recurrence rate was significantly lower for patients who underwent blue light cystoscopy. This meta-analysis did bring up the point of false positives. It seems like in some studies there is a higher false positive rate for patients who undergo blue light cystoscopy. This is more prominent in patients who have undergone recent TURBT, who have concurrent infections or inflammation, or for patients who have recently received intravesical therapy. Some of the overdetection is thought to be improved if you delay when you do a blue light cystoscopy after receiving intravesical therapy. So they previously said 3 months, and now 6 weeks is what's recommended. False positive rate, anecdotally at least, seems to decrease over time with user experience as well. So it seems that blue light cystoscopy allows patients to have better cancer detection rates, better recurrence rates, but is there any evidence to suggest that progression is different between these two groups? And I think the jury is still out on that. I don't think that that's a widely accepted thought. There was one study with 550 patients, which also looked at the difference in detection and recurrence for patients who had blue light cystoscopy. And in this, again, recurrence was improved in the patients who underwent blue light cystoscopy, but then they commented that the percentage of patients in the blue light group who went on to cystectomy was actually decreased compared to the white light cystoscopy group. However, that didn't reach statistical significance. In a follow-up systematic review of 6 separate studies with a median follow-up of 38 months, in this study, they reported that a higher percentage of patients who underwent white light cystoscopy ended up going on to receive cystectomy as compared to blue light cystoscopy. And that did reach statistical significance. And the thought that some people believe as to why blue light may help with progression is that they think that you may be able to do a better resection, or that you might actually be placing these people in different treatment algorithms that you wouldn't have otherwise. But like I said, I think the jury's still out. It's not a widely accepted point that it affects progression. So what does all of that data really mean? We've talked about better recurrence, better detection rates with blue light cystoscopy. So ultimately what that boils down to is two statements in the AUA guidelines regarding non-muscle invasive bladder cancer. So the take home from all of that is that patients who have non-muscle invasive bladder cancer, who have a normal cystoscopy and positive cytology, we should consider using blue light if it's available to us. And that was based on expert opinion. The other statement in the guidelines is that in a patient who has non-muscle invasive bladder cancer, a clinician should offer blue light cystoscopy at the time of TURBT. So now what about surveillance? The main goal of bladder cancer surveillance is to detect recurrence and progression. As the body of evidence sort of accumulated that there was earlier detection of tumors by blue light cystoscopy, there had been some growing interest in studying whether or not incorporating blue light cystoscopy in the office with flexible cystoscopy could improve patient outcomes. So in 2018, there was actually a prospective phase 3 study that was conducted and evaluated whether the addition of blue light cystoscopy to white light cysto during office surveillance led to improved cancer detection. This study enrolled 304 patients across the US. Essentially, patients all received Cysview 1 hour prior to their office cystoscopy. They would get the installation, then they would go back and wait in the clinic waiting room, and they would come in and get their cystoscopy. Once the white light cystoscopy was performed, the patients would then be randomized to either receiving a blue light cysto or no further intervention. Based on that, 103 patients were taken to the operating room because there was something seen either on the white light cystoscopy or something on the blue light cystoscopy. And the primary outcome was for them to determine how many patients would go to the OR and be diagnosed with a tumor based only on detecting something with the blue light in the office. So that was their primary outcome. They essentially wanted to know if they didn't use blue light, how many patients would not have been diagnosed with bladder cancer. These are just some of the demographics of this study. Most of these patients actually had TA or CIS disease, and most of these patients, 202 of the 304 patients actually had high-grade disease. So this was more of an intermediate and high-risk bladder cancer population. I think 2/3 of the patients had actually received prior BCG. The average amount of prior resections was 1.7 for each patient. And it had been about 5 months since the patients had their last TUR. These are some of the results. So 61% ended up having histologically confirmed bladder cancer on central pathology review. So their primary endpoint of finding the percent of patients who had cancer detected only by blue light on office cysto, it was actually 13 patients were detected to have bladder cancer. And these were patients who only had something on their blue light cystoscopy in the office. There was one case of a tumor on white light cystoscopy that was not picked up by blue light. There was no difference in the false positive rate. They looked at the safety of Cysview, and for the most part, there was a 2 to 3% adverse reaction rate. Most of the complaints were dysuria or bladder discomfort, erythema. they concluded that prior exposure to Cysview did not affect the likelihood of adverse events. And because of that, it's okay for patients to receive Cysview multiple times. Another thing they looked at in this study was patient-reported outcomes. As you can imagine, coming to the office, getting an extra catheterization, having to wait an extra hour for your cystoscopy may not be something that patients really want. But when you look at the satisfaction surveys, the vast majority of patients actually said that it was worthwhile, that they would do it again, and that they would actually recommend it to others. So conclusions from that paper was that there was improved detection of recurrent bladder cancer with flexible blue light cystoscopy in the office, that it was safe to use, and that it was well perceived by patients. Based on all of this, there was a consensus panel at the 2018 AUA. The panel really consisted of 17 investigators, most of whom were actually on the phase 3 trial. They stratified the use of flexible blue light cystoscopy in the office based on bladder cancer risk. And I'm just going to highlight the main takeaways from that. So for patients who have a low risk non-muscle invasive bladder cancer, this is a table. R just stands for rigid cystoscopy, F is for flexible. In the shaded boxes, if you have a navy blue shade, that means there's a strong recommendation. And so for low risk non-muscle invasive bladder cancer, there were no strong recommendations for flexible blue light. For patients who had intermediate risk disease, the two strong recommendations from the consensus was for patients who have intermediate risk non-muscle invasive bladder cancer. If they're going to go on to receive a repeat TUR in the operating room, they strongly recommended blue light. And actually at their initial surveillance, 3 months following their initial TUR, they recommended blue light. For patients who are high risk, essentially the same thing. If they were going to get a repeat TUR, they recommended blue light. And at their initial surveillance at 3 months, they recommended blue light. There was some sentiment also that perhaps surveillance of these high-risk patients could also be performed in the clinic setting with blue light, but the strongest recommendation was just for initial surveillance at 3 months. What are some of the cons? There's a lot. There's a dwell time in the clinic. There's an extra catheterization for the patients. There's false positive rates. There's longer time of having the scope in the patient as you're flipping through blue light and white light. After you instill the agent in the bladder and you put your camera in, you need to suck out all of the urine. There's costs associated with this. And if you're going to start doing this in your practice, you would need to have, dedicated nursing staff who understand what is going on. You would have to have, you'd likely need multiple scopes because a lot of us do multiple cystoscopies in a single day. In terms of future directions for Cysview, there's still interest in learning about the efficacy for patients who have low and intermediate risk disease, interest in the cost effectiveness of this, as well as interest in using Cysview as a photodynamic therapy in conjunction with specific wavelengths of light as a means of destroying urothelial cancer. So is there a way for Cysview to be used as therapy? So this is a sort of summary slide. These are the things to take away from the discussion, in my opinion. So when do you use blue light cystoscopy? You can use it in TURs for non-muscle invasive bladder cancer. You can use it for TURs in patients who have negative cystoscopy and cytology. And we know that it is used for in-office. It is approved for in-office use, with the strongest recommendations being for patients who have high-risk disease using flexible blue light at their initial 3-month surveillance. That's it. I'm happy to take any questions.
Good job, Jamil. I just have a quick question for you, and I'm not sure if there's an answer, but has anyone thought about using blue light for upper tract surveillance, especially if someone's got a positive cytology? I
think I did read some, I don't think there's robust data on that, but yes, people have looked at blue light for upper tract. I'm not that familiar with the data, but I do know that people are using it.
Okay, what about any of the the physicians in our group who use blue light, do you think it's been very helpful in your clinical practice? I don't know if like Preston or Mike Liebman have been using it.
I don't. This is Preston. I don't use it. I think that it mostly because it has. I don't do a ton of bladder patients these days where.
You muted out, Preston.
I
Sorry.
think
I know that Dr. Kenny thinks it's a modest benefit.
I think if someone has a positive, it's reasonable.
Okay. Who does anyone else in this group use it? How about David Hess? Do you use it?
Yeah, I think it has value, but I think the biggest issue at our institution is it's very nurse intensive. And when I've used, and it's only, over at York Street. So I think the nursing staff really needs to buy into it, and there has to be some consistency in delivering the CIS view an hour before, make sure there's adequate dwell time, make sure the tower is working, make sure the scopes are working, because otherwise it often becomes a, not very valuable in working it up. But in a perfect setting, if you can have, the right support staff, and it's a nice part of the armamentarium. And I think in a perfect world, it would be something that we could all use, and there's modest benefit, I think.
Okay. Any other questions?
I don't have anything in the chat right now.
Okay. All right, wonderful. So, all right. Thank you. Everyone have a wonderful day.
Great job, guys.